Hello, this is Jacob with Gastroenterology, presenting the April, albeit somewhat late, portion of the monthly digest discussion. This month's main topic was regarding esophageal motility disorders, my selected subtopic being over Zinker's diverticulum and the associated use of a barium swallow study to evaluate for this. So esophageal diverticula plural, are an outpouching of single or multiple layers of the esophageal wall. Single Zinker's diverticulum is the most common form of esophageal diverticula, and they occur in an area of the posterior hypopharynx or cervical esophagus known as Killian's triangle, an anatomical landmark with intrinsic weakness between the cricopharyngeus muscle and the thyropharyngeus muscle. A combination of factors, including upper esophageal sphincter dysfunction, altered esophageal motility, esophageal shortening, increased intrabolus pressure, and GERD, predispose to the risk of herniation within Killian's triangle. Prevalence of Zinker's diverticulum is not well known given the presumed large population of asymptomatic individuals. However, it is older aged males, specifically within the 7th and 8th decade of life, who represent the most common population to experience symptoms from this. Here's two images kind of showing a gross anatomical view and then much closer view of the area of the posterior esophagus where this herniation and outpouching of the esophagus occurs. Largely, the symptoms of Zinker's diverticulum are dependent upon the size, as diminutive diverticula are likely to be asymptomatic and only found incidentally. Oropharyngeal dysphagia may occur when food is diverted from the oral cavity to the diverticulum located in the hypopharynx. Retained debris of food, mucus, and medication lead to halitosis, a sensation of esophageal obstruction, over time can cause weight loss, and as an immediate or delayed regurgitation of food into the oral cavity, they pose a risk for aspiration. This occurs particularly when patients eat dinner, lay down, and go to bed, and then have an aspiration event overnight. Infrequently, very large diverticula with retained contents can expand anteriorly and cause esophageal luminal obstruction. So, kind of further with that, aspiration pneumonia is one of the most severe complications of Zinker's diverticulum, but also retained food and medication, particularly those that are caustic and irritating, the debris of which can cause ulceration and erosion of the esophagus with potential for bleeding or even fistulation that communicates the esophagus and tracheal lumen. Vocal cord injury, including paralysis from extrinsic compression by an impacted diverticulum. And then there is a low but associated risk of squamous cell carcinoma of the diverticulum. I believe the reference on UpToDate estimated as a 0.3 to a 1.5% risk. However, they noted that patients with additional comorbidities and risk factors such as tobacco use or any kind of family history, as well as male gender or advanced age, are at highest risk amongst the population for developing malignancy. So the diagnostic approach to evaluating the presence of Zinker's diverticulum is often undertaken by a modified barium swallow study, which is a dynamic swallowing study used to appraise individuals who have a difficulty initiating a swallow or have a suspected risk for aspiration, or those who are suspected to have a Zinker's diverticulum. The MBSS is a dynamic continuous fluoroscopic examination, and it's superior to a static examination like an upper GI series to evaluate abnormalities of the pharynx and hypopharynx upon ingestion. Typically a viscous barium solution, but additionally consistencies such as pudding or crackers or wafers are ingested and visualized with continuous imaging as the propulsion of food contents is observed to go down the esophagus. And in the presence of a substantial Zinker's diverticulum, the barium solution is observed to occupy the confines of the diverticular pouch, particularly, and I included towards the end of my references a YouTube video link to watch an actual swallow study. You can see that the liquids spill quickly, but then they empty rather quickly as well. But solid substances tend to occupy the area for a more prolonged period of time, in fact, requiring further ingestion of a liquid to kind of wash that area out. Nonetheless, smaller diverticula may not be as readily identified. Subsequent upper endoscopic evaluation is recommended to exclude any concurrent malignancy, as well as offer the opportunity of endoscopic diverticulectomy, as we see typically performed in the outpatient clinic setting. So here's two images, one from a barium swallow study showing contrast occupying the diverticulum, and then the other is from direct endoscopy, and you see the actual esophageal lumen, and then it's an occupied diverticular pouch with either food or some sort of gunk in it. So the recommendations by UpToDate is that treatment is recommended for any symptomatic patient, but also for any asymptomatic patient, even with an incidental discovery of a Zinker's diverticulum, if it's greater than 1 centimeter in size. An interventional approach to the definitive treatment of Zinker's diverticulum include open transcervical surgery or transoral endoscopic diverticulectomy. Post-procedure, we often will see these patients after the time they already had their nasogastric tube removed, by the time they actually make it in the hospital. But nasogastric tube is left in place with subsequent monitoring and performance of a chest radiograph to exclude any perforation. Typically, patients are receiving an antibiotic while over in the clinic prior to arriving to the hospital. And at times in the past, we've seen patients that get subsequent doses of either IV or going home on oral antibiotics for this. And so kind of given that inconsistency, I wanted to look to see what up-to-date recommendations were. And overall, there appears to be kind of a lacking data and consensus on a solid recommendation regarding how many doses and what type of prophylactic antibiotic therapy is recommended for these patients. Similarly, for the duration of time that they must remain NPO or restrained to a liquid diet. In general, these patients are at least kept to a liquid consistency diet throughout hospital stay and advanced sometime thereafter. Pain management, of course, is one of the most common things that we'll have to address during their inpatient stay, as the complaint of post-procedural discomfort is probably the most common thing that we hear reported. Patients are often given a GI cocktail to provide some local relief there to the area of the esophagus. There is no specific recommendation for the necessity of any follow-up imaging, like an additional barium swallow study post-diverticulectomy, to confirm the success. Here's the references again. In the yellow, if you click on it, should be a hyperlink to take you to that video of the barium swallow study that depicts a Zinker's diverticulum. All right, thank you for your time.